Hello. Welcome to episode 2 of this 3-part podcast series, which accompanies a recent report by the Ada Lovelace Institute, Access Denied. The report is part of a collaboration between the Health Foundation and the Ada Lovelace Institute to study and understand how data-driven systems in healthcare impact and relate to health inequalities. I'm Kira Allman, and I'm a digital anthropologist, which means I study people's lived experiences of technology. And, spoiler alert, that means I spend a lot of time thinking about inequality. Because the introduction of new technologies doesn't benefit everyone. And in some cases, it can even make life harder or worse. You've probably heard of the concept of the digital divide, that some people have access and skills to use computers and other technologies, and others don't. But as the digital world has expanded and technologies have gotten more advanced and complex, digital inequalities have too. One big factor in that is
Data.
What academics call datafication, the production and collection and analysis of loads of information about people and their behaviors that then gets used to deliver services like social media or, well, healthcare. Data is crucial for algorithmic processing, machine learning, and AI, and we produce tons of it. But data can never tell the complete story about someone's life. And it can't overcome some of the everyday exclusions and barriers people face in dealing with their health and healthcare more generally, something we talked about in the first episode of the podcast. In this episode, we're going to talk about why that is. We're going to try to understand the emotional life of data. Behind every disembodied bit and byte of data is a context. In our case, human beings and their health. And we're going to highlight how context is key when it comes to data and digitization more broadly. In the last episode, we introduced our team of peer researchers who each have lived experience of poverty. In case you missed them, they are
Brian Scott.
Stephen Porter.
Karina. People call me Kai. Karina or Kai's fine.
Caroline.
and
Tracy.
These peer researchers are all members of the APPLE Collective. APPLE stands for Addressing Poverty Through Lived Experience. Throughout the course of this project, they conducted interviews in their own communities, focusing on patients' experiences in a rapidly digitizing NHS. And what they heard was mixed.
Most of the people don't want to do digital healthcare. They want to do face-to-face. You want to talk to a human. People are often looking for like empathy. You're not going to get it through a digital Zoom or anything like that. It seems more that it's like more of a program than like a human being. And that's not how a human being wants to be treated.
If it's easy and it's an easy guide or whatever to do it and it works well from the start, then it's great and you get used to that system and you're comfortable with that. But I think if you come up with like hurdles straight away with certain services or digital access, then it can be quite frustrating. And I think a lot of frustrations have come from people that I've spoke to.
You get the picture. In spite of the promise of a digital, data-driven healthcare system that makes healthcare better for everyone, people aren't always seeing that promise realized in their own lives. And what came up over and over again was understanding the context in which data is collected and used. An important part of that context is how people feel about the way they're treated in the healthcare system. Data-driven technologies and systems now play a role in the emotional experience of healthcare, and it's easy to forget that. Here's Tracy.
We've been forced into this digital and over-the-phone access because of lockdowns and what have you. And not everybody wants to deal with it, and it's not really working. Those that are delivering the care are frustrated that they can't give the care that's needed because there's either not the funding or not the services in place to deal with them. Those that are trying to get access to the services that aren't available or haven't got enough funding And the general consensus seems to be that we need to go back 30 years.
Data is supposed to help us make more accurate decisions, to make us more certain about causes and consequences, and more efficient at identifying and treating problems, right? The peer researchers sometimes identified these positive possibilities.
The strengths would be where you have the transfer of communication and information. I remember the days of the old medical records where you'd get some medical records, especially the elderly patients, which could be 12 inches thick. It's not unusual for a person's medical records to be that thick. Now, with increasing computerisation, you can go for a CT scan, go and get an ECG scan, go back to the outpatients, and information from those two previous departments are there waiting for you, so that the doctor you initially were going in to see at your outpatient's appointment has got all the information to hand. So there's no delay there, and it should help the speed of a diagnosis and treatment.
But what if, in the quest for greater accuracy, efficiency, and objectivity through datafication and digitization, we lose sight of the subjective choices that go into data collection and analysis, and the subjectivities, the personal feelings and opinions and experiences of the people whose data is being collected and whose outcomes the healthcare system as a whole is trying to improve.
For this project, we wanted to highlight the perspectives of people with lived experience of health inequalities to uncover the everyday interactions they have with digital health services, to understand the ways in which experience of things like poverty and chronic health concerns impact how well digital health services work for people, and how much of a role context has to play in this as well.
This is Anna Studman, a senior researcher at the Ada Lovelace Institute.
We also really wanted to centre the voices of people who aren't often heard in healthcare policy.
And some earlier research we had done had already pointed to some of the ways that inequalities find their way into system design and become the product of data-driven systems too. Here's Mavis Machirori, another senior researcher at the Ada Lovelace Institute, who led that part of the research, which turned into a report called The Knotted Pipeline.
So what we found were 7 main issues that we called knots. So areas where information was hitting a barrier and wasn't able to produce the good outcomes that were intended. The main one was that inequalities themselves were difficult to describe, or in some cases not well understood. Another issue we found, the second knot, was that there was this misalignment, differences between the priorities and approaches between the local public health officials and what was happening on the national scale. Other knots revolved around the way data was handled, where data that was being used to build these systems didn't always bring in the context in which that data was collected. The fact that some designers of systems were taking data to be the truth, so what they saw in front of them was the way the world was.
When it comes down to the patient experience, though, most of these systems aren't visible. They're behind the scenes. What patients do see are the technologies they come face-to-face with in their everyday interactions with the healthcare sector. The peer researchers heard time and time again about frustrations people feel with new technologies like video consultations. These experiences drive a wedge between people and healthcare professionals and make it harder to access the nuanced emotions patients bring to a doctor's appointment. There's a perceived erosion of human-to-human contact, and that is one of the biggest downsides to digitizing healthcare.
Well, there's definitely a place for digital healthcare. It's just when you go down to like GPs, you really need a face-to-face. The human touch. I mean, when we were younger, we all had family doctors and they knew everything about you. They didn't have to sit there and go through data. You go see a doctor nowadays and it's all written down on the computer.
Where digitisation and computerisation fall down is the human touch, where just sitting down and speaking to someone the night before an operation to put their mind at ease is going to have a beneficial outcome for that patient's operation.
And the utterly commonplace technology that seemed to epitomize this problem? You guessed it.
Zoom.
Zoom meetings.
There was not a lot of love for Zoom, a video conferencing platform popularized during the pandemic. Video calling flattens the context of a patient's experience. It literally confines the interaction to the screen.
You can't do a face-to-face consultation on a Zoom because, I don't know, you couldn't show parts of your body. It doesn't feel real.
People wanting definitely a mix of both. I think that was the main thing that stuck out. Even the most, digitally savvy or whatever of who I interviewed would still like to have that option of, if needed be, to be face to face, they would still like to have that option.
You can't see the whole story of a patient's condition on a Zoom call.
You can't be sending pictures of, say, your hand or your foot or any other place on your body. Because let's face it, a phone has its own filters. Different light settings can change the colour of your skin slightly as it is.
Zoom here probably stands in for a broader issue, a perception that efficiency trumps empathy. Where's the care in healthcare?
When you speak to a lot of people with lived experience of poverty, you feel as though you're not being heard, you're frustrated, you put a barrier up.
It all depends on the individual themselves. A lot of people don't even know how to use a mobile phone, let alone be able to use a computer. And take my parents, for instance. My mum won't even have a mobile phone. She calls the landline, because it's wireless, she calls that the mobile phone. There's a lot of people who can't afford computers or laptops.
Half the time they don't listen to you and they write the opposite of what you tell them. And I don't know whether it's because they're not listening or because they're lying, and I don't know which is worse.
There are some things that a digital interaction cannot replicate, and no amount of even the most accurate data can compensate for. And that's the feeling of being safe, being cared for, being trusted as an expert on your own body and your own life.
I've been trying to get to see an arthritis consultant for years. I didn't even get told I'd got arthritis. I just read it in my notes. And I went to the doctor and said, this says there's no OA changes, and this was from 2016. So they'd obviously put before that I'd got osteoarthritis, never told me. So I went to the doctor and I said, does that mean I've got arthritis? And he said, well, if that's what he says, that's what it means. And that's as far as I've got, really.
And it's worth saying, the lines get blurry between distrust of the healthcare system in general and distrust of technologies specifically.
I don't trust digital. I mean, if every computer went wrong, data would all be lost. I believe in the old-fashioned paper books. I never use it unless I have to, and I don't like it.
But hey, that's kind of understandable. Data-driven systems, digital technologies, they're tools to help achieve certain outcomes. They fit into a bigger system that hasn't solved some basic inequalities, like unequal access to services, unequal quality of facilities and spaces, unequal treatment of marginalized, racialized, or otherwise stigmatized patients, and unequal health outcomes. Come on, listen to that list. Technology is not going to solve that. Here's Tracy, a coordinator with the Apple Collective.
Everyone, whether you were in a deprived area or even an affluent area, unless you were in private medical care, your first point of contact is always ring a doctor's surgery at 8:30 on the morning. So 8:30 on the morning is a school run as well, and that's never took into consideration. And if you don't get the phone answered within the first 5 or 10 minutes, you're just not getting in that day. It's as simple as that. And then the other reliance is on completing any consult form online, which is great if you've got access to the internet, if you're quite comfortable with filling in a form like that. But it still has the potential of misdiagnosis as well, because you're working on a limited amount of information or your own self-diagnosis, and you can't have a full in-depth conversation. There has to be different options, because not everyone is digitally savvy, connected, or comfortable with doing that.
And we heard about these inequalities from the peer researchers too.
I'm a big advocate for disabled people's poverty, because you get children's poverty, pensioners' poverty, everybody's poverty is always highlighted, but people with disabilities are always left out. And there's been a 56% rise in disabled people having to use food insecurity hubs And to me, they need more help and support.
This doesn't mean that we should stop digitizing full stop, pack up and go home. But it does mean that people building data-driven technologies for healthcare or making data-driven interventions need to focus on patient participation and trust. They need to make the reasons for using data and digital technologies clear. And they need to spend the time, and it does take time, to understand the lived experience of the incredibly diverse population of people behind the data that powers our digital future. How data is collected and used has a real, felt, emotional impact on people's lives.
Going through like mental health, drugs and alcohol services, it's more conclusive that you have gone through traumatic ordeals, and you shouldn't really have to relive that every single time you go and see a different physician, because it's just re-traumatizing you every time you have to go through the story. A lot of people have had traumatic childhoods and traumatic relationships. They shouldn't have to relive all this just to explain themselves. I mean, they've already probably explained themselves 1,000 times by the time they get seen to properly. There's not enough empathy in the world to deal with it. They shouldn't have to keep going over a story, especially if it's already written down for someone to read.
What's the point of designing a system without the voice of lived experience, whatever form that comes in, whether it's through poverty, through digital inequalities, through health inequalities? If you don't have the voices of the people who have experienced those and who you're aiming the services at, then you can't possibly serve the needs. In my experience of the people who are designing the new digital systems, they're getting too hung up on what they could do rather than what they should do. And they're putting in systems because there are systems available and the technology is available rather than what's actually going to benefit the patient.
Ask, like me as a disabled person, what would be easier for me to do, and then ask somebody else who was blind or somebody else who couldn't talk, ask somebody older, somebody young, engage every part of the population to find out what would work best. Don't just have one and everybody can try and use it.
There's some good news, though. On September 29th, the NHS announced plans to involve the public in shaping policy on how their data is used in the healthcare system. This kind of listening is crucial to building systems that serve people, rather than systems that people need to serve. But if there's a lesson here for that public engagement project, it's that inequalities have to be front and center. It takes work to involve people who often fall through the cracks, and it can't just be a tick box exercise or a one-off. Trust has to be tended, or it withers, and we shouldn't ignore how people feel about their health and care. Data-driven systems do not have to be unfeeling to be accurate and efficient. We can put people at the heart of digital transformation. We have that choice. We have that power. Let's use it. This podcast was produced by Cherry Soup Productions for the Ada Lovelace Institute and the Health Foundation. It was recorded and edited by Ciara Allman and Connor Malloy. Music was by Connor Malloy. If you would like to learn more about this project, go to adalovelace.org and read the report that accompanies the research, Access Denied. And don't forget to check out the first episode in this series if you haven't already, and keep an eye out for episode 3, our final episode, which looks at the participatory methods we used in this project.